Madam, now we can start.
Hi, welcome to this another webinar series on innovation in hematology. And today we have Dr. Kamran Mirza from Michigan University. Just to give you a brief background, Dr. Kamran, we are a group of 15 hematologists working in Fortis. We have got a 12-color flow cytometry, which is being headed by Dr. Astha, along with 4 hematopathologists, along with a full-fledged genetic department. And as we go on, we are looking for a spatial flow cytometry at this present moment of time to come into the department. And these webinar series has been started from June this year and has been a great success. People across 30 countries tends to join, right from West Indies to Mongolia to Kenya, where I am right now, and across Bangladesh, Vietnam, Myanmar, Nepal, and Central Asia. The idea of these webinars is to put in the question and answer form so that we can discuss the nuances of MDS and can learn and collaborate with the great advancements which are taking place at this present moment of time in the field of hematology, right? Integrating the flow cytometry to genomics, and not to forget basic hematopathology and the morphology, which still holds the guide for our treatment on a day-to-day basis. So with this and under Dr. Astha tutelage, we have been able to establish this world-class department at Fortis. So with this, I hand over to Dr. Astha to introduce Dr. Kamran Mirza, who has been gracious enough to give us the guidance and agreed upon to this webinar series, which will enrich many people across the world. Thank you. Over to Dr.
Astha. So a very good evening to all of you and good morning to Dr. Kamran. Nishant, can you please mute yourself? Nishant.
Dr. Astha, before you proceeded, I would request everybody to mute your speakers.
और साइड के पैनल में सब लोग दिख रहे हैं.
Nishant, please mute yourself.
Can we mute everybody, please?
Yes, sir.
Dr. Astha, please go ahead.
Yes. So a very good evening to everyone and a good morning to Dr. Kamran. We invite you to another exciting session of innovations in hematology under Fortis Institute of Blood Disorders. And today we will be dealing with a very challenging entity of hematological disorders, which is a myelodysplastic syndrome, now called as myelodysplastic neoplasm. How the several key factors which are important in the diagnosis of myelodysplastic syndrome, and to create more objectivity, more uniformity, and an integrated approach by morphology, flow cytometry, and genomics is really required to establish the correct diagnosis of myelodysplastic neoplasm. Our esteemed guest for today is Dr. Kamran Mirza. He is a professor of from Michigan University and a Grott Professor of Pathology, Assistant Chair for Education, Director to many students. He has several accolades to his honor, and there is a long list of awards, sir, in your name. And many students actually seek guidance from you when they are wanting for match in pathology in states. Before handing over the mic to Dr. Kamran, I'd like to inform you all about our upcoming webinar on 23rd of November on combating antimicrobial resistance in immunocompromised patients, challenges and new solutions by Dr. Abedan, moderated by our Dr. Neha. And this is our team at Fortis, where we all clinical, the pediatric, adult, and the lab team, we come together, we work together for the diagnosis and better care for the patient. So I'll stop sharing my screen and I'll invite Dr. Kamran to please share his screen and insight us.
And Dr. Astha, before Dr. Kamran comes in, Dr. Tathagat Chatterjee has also joined in, who's the president-elect for Indian Society of Hematology and Blood Transfusion. We welcome Dr. Tathagat Chatterjee, sir, also on this webinar. Over to Dr. Kamran.
Thank you. Thank you very much. Good morning from Michigan and good evening to all of you. It is a great honor and pleasure to be speaking to you all today. Thank you to Fortis and to Dr. Asta and all the hematologists and in this great group. It seems that you are doing fantastic work, and I am so humbled to be kind of talking about myelodysplastic neoplasms, like Dr. Asta said, or MDS. So as was mentioned, I'm a professor of hematopathology at Michigan, the University of Michigan. And as many of you may know, part of my passion is teaching across the globe, and I do that really through social media. So for any of you who are interested in connecting with me, whether it be on Facebook or X or all the other social media platforms, the QR code takes you to my link tree, which will allow you to kind of find me on all those platforms. I'm happy to connect with all of you. So today I was asked to speak about how we integrate different ancillary tests, including flow and genomics, for the diagnosis of MDS. So while its name has been changed to myelodysplastic neoplasms, we still call it MDS. So that at least is simple. But the idea is that let's talk about kind of how we approach these cases. And what I decided to do was talk about specifically what is different and what is the same in the two classifications of hematopathology, the International Consensus Classification and the WHO. And so using that, I think we can have this conversation. So for the trainees in the audience, I find that it's very helpful because MDS or myelodysplastic neoplasia can be kind of a tricky topic. And so for any of you who are trainees in the audience, let's start with this idea of what is normal hematopoiesis and how it converts to myeloid neoplasia. So normally you will have in the bone marrow, like we all do, a certain number of undifferentiated normal stem cells. And in the hematopoietic world, that leads to a reasonably cellular bone marrow biopsy. So if you see bone core biopsies, it's pretty cellular. It has trilineage hematopoiesis and appropriate maturation across all cell lines. And this factory leads to the production of correct number of cells. And so your peripheral blood film looks pretty normal, and there's no anemia, and there's no leukopenia, and there's no thrombocytopenia. So ultimately, this is the normal state of affairs. But we know due to a variety of factors, it's very possible that we accumulate or accrue genetic mutations within the stem cells that will cause an abnormality that will allow that stem cell to clonally proliferate, and that is abnormal. Now, clonal hematopoiesis can still look normal. When you look at the bone core biopsy, it looks like the hematopoiesis looks exactly the same. There's no morphologic dysplasia on the aspirate smear. And when you look at the peripheral blood film, it looks very similar. So you can have an element of clonal hematopoiesis that's just genetic, and it does not show up in the patient's CBC or in the differential. However, in the setting of the perfect storm, I would say, of mutations and or cytogenetic abnormalities, and in the case that we cannot clear this clone, you put together those mutations or cytogenetic abnormalities in the setting of epigenetic factors in the microenvironment, depending on what type of exposures your patient has, you can ultimately come to a situation where you have a oligoclonal or polyclonal but abnormal process that's happening, but the clonality here is effectively kind of multiclonal in a way, right? And this will lead to morphologic dysplasia. And typically, there is ineffective hematopoiesis, where the marrow will still be very cellular, but there will be cytopenias with or without morphologic dysplasia in the peripheral blood, right? And so that is what we do when we think about myeloid neoplasia. Now, once you have those clones, we can think about how to subclassify it, but this is at baseline, the understanding of how myeloid neoplasia occurs. In the new WHO, this series of next two images are very helpful to me. And so if we kind of follow along, these are the patients with no detectable somatic mutation. So, the majority of us are like this. And they still have normal blood cell counts, right, all the way through here. So ultimately, there are ubiquitous low frequency mutations that will happen in many of us, but that doesn't mean that something will happen, meaning that it can just be hanging around and we don't have any cytopenias. Now, clonal hematopoiesis of indeterminate potential is basically when, due to either the genetic predisposition, inflammation, exposure to cytotoxic agents, an immune attack, or things like smoking, there can be a clonal hematopoiesis of indeterminate potential in these patients. But remember, they will still have normal blood cell count. There's no cytopenia This is known as
They
CHIP.
would
So
be
CHIP is clonal
how
hematopoiesis of
much is
a
the
potential. However, there could be cases which continue with those ubiquitous low frequency mutations and they do not have any CHIP. Now, CHIP by itself does have a risk of progression to AML or MDS or MPN of around 0.5 to 1% per year. And that really depends on the variant allele frequency of the mutations, the number of mutations, what the driver gene is, and whether there are acquired chromosomal mosaicism happening as well. Now, these patients can obviously move forward to MDS, which is what we'll be talking about. However, that's not always the case. In some cases with CHIP will also not produce AML MDS, but also have non-hematological sequelae like cardiac disease, which the no CHIP people also get. So this was CHIP, meaning that there's a clone and there is clonal hematopoiesis, but there are normal blood cell counts. Now, in contrast, let's say those patients who present with unexplained cytopenias, they're already starting with cytopenia, right? And so when there's a clone and there's cytopenia, you call that clonal cytopenia of undetermined significance if the morphologic dysplasia is not present. So why can people have unexplained cytopenia? You have to rule out vitamin or mineral deficiencies, hemoglobinopathies, autoimmune conditions, congenital conditions, toxic agents or inflammation, and obviously anemia of chronic disease. Once you've kind of explained out or ruled out all of those causes of cytopenia, when you do a bone marrow examination associated with the FISH and next generation sequencing, if you find that these patients who have these cytopenias, there's no reason for them, but there's no mutation, then you will call them idiopathic cytopenia of undetermined significance or ICUS, right? ICUS. However, if the bone marrow examination and the studies find a mutation that is clonal, then you will call them clonal cytopenia of undetermined significance, and their risk of progression to AML, MDS, or MPN is much higher than CHIP. It is up to 10 to 20% per year, but again, this depends on the variant allele frequency, the number of mutations, and the driver genes, right? And so ultimately, you can get to CCUS and then to AML MDS. But remember, there are patients who won't go through the CCUS process. They'll go directly to AML, MDS, or MPN. So that said, we've established this idea that normal stem cells, when they have mutations, they can give us clonal hematopoiesis. If there's also cytopenia, it can be clonal cytopenias. But in all of these cases, we have not defined MDS because there is no morphologic dysplasia. So then question is, how do you establish the diagnosis of myelodysplastic neoplasm or MDS? And I would say that to build this building, the three pillars are going to be the blood counts, the morphology, and the genetics. So when you take into the blood counts, they take into account the blood count, this will confirm that hematopoiesis is ineffective, right? So you do need to have cytopenia. If there's no cytopenia, it's unlikely that you will be calling something myelodysplastic syndrome. Morphology will confirm that the hematopoietic cells are functionally abnormal, and that is important because functional abnormalities will be the reason why the patient is having that ineffective hematopoiesis in the first place. And then genetics is important because sometimes the morphology may not be that overtly abnormal, but the genetics can be diagnostic, and so that will confirm that the hematopoiesis is truly clonal. So as I mentioned in the beginning, in the last few years, we now have two classifications of myeloid neoplasms that came out in 2022, 2023. The ICC is on the left, and it came out as a special report in the journal Blood from the American Society for Hematology. And most of the authors here are from the prior WHO versions, and the first author is Dr. Dan Arbor. The WHO classification got a series of reasonably new editors. It was just different, and that came out not only online, but now has come out as two kind of booklets of the WHO. And so I think that as people who diagnose hematologic conditions, the practice varies. Some people use one or the other, and some people use two. At our institution, if there is a significant difference between both of them, we actually use both of them, and we put both the diagnoses in. So now that you have two classifications of myeloid neoplasms, we have to kind of consider, is this a crossroads or what do we do? And so many MDS entities are similar, luckily, in the WHO5 and the ICC, or they've been unchanged from 2017, which is great. The important thing is that both of them rely increasingly on genetic data. There are also several significant differences. These could be differences in nomenclature, and some differences are in diagnostic criteria for specific entities, and there are some new entities recognized in one classification and not the other. The important thing is that morphologic dysplasia still remains the most important part of differentiating myelodysplastic neoplasms from non-malignant cytopenias. They have retained the 10% morphologic threshold in both WHO5 and ICC, so 10% of a single lineage. And remember, the dysplasia, though, is imperfect and it's not always reproducible and it's not specific for myelodysplastic neoplasms. So, cases of copper deficiency can look very dysplastic. Cases with some medications can look very dysplastic. And so it's not always specific. And one person can think that it's 12% dysplasia, the other person might think it's 8. So this is not ideal. However, it still remains the most important part of the triage process of this diagnosis. In both classifications, the MDS precursors, CHIP and CCUS, have been acknowledged, and they have identical definitions. But they've also talked about VEXAS, paroxysmal nocturnal hemoglobinuria, and clonal aplastic anemia, which I will not be discussing today. So I think that in order to kind of proceed about how to integrate all of these things, I think it's interesting to think about where we were in 2017 when we had the unified criteria. So the way I kind of think about this is that, you either have less than 5% bone marrow blasts, and in which case, if you have less than 5% bone marrow blasts, you're not going to call it MDS with increased blasts. So you're now going to look at that time in 2017, whether there's single lineage dysplasia, whether there is multilineage dysplasia, whether there are ring sideroblasts, and whether there is lesion 5q. This was the important stuff to consider if there were less than 5% blasts. Now, if there were more than 5% blasts, but under 10, then we knew that in the 2017 criteria, this became myelodysplastic neoplasm with excess blasts 1. And if you had 10 to 19%, obviously we knew that this became MDS with excess blasts 2, because 20% would have made it acute myeloid leukemia. So this is the baseline with which the 2017 criteria was. And for the most part, many things did not change in this, but this is a good baseline for us to think about. So the question then is that morphologically, this is how we were classifying it. And so the major thing we had to ask ourselves is, can new genetic information revolutionize MDS classification? So we know, and this was published in Blood in 2013, that myelodysplastic neoplasms are characterized by mutations in over 40 genes, a complex structure of gene-gene interactions, and extensive subclonal diversification. And so the total number of oncogenic mutations and early detection of subclonal mutations are significant prognostic variables in myelodysplastic syndromes. And you can see that the number of patients with the mutations are here on the left. And you can see the old 2017 classification: refractory anemia with ring sideroblasts, refractory cytopenia with multilineage dysplasia. They're all color-coded, and so these bars are color-coded based on how many of those patients had those particular mutations. So here you can see the spliceosome factor, SF3B1, is very high, but then if you look at the top few, it's SF3B1, TET2, SRSF2, ASXL1, and deletion 5q. There's also DNMT3A, RUNX1, and then complex karyotype. And so these are the ones, and then obviously we have to talk about TP53. So these are the kind of ones which you want to consider important for because they are recurrent in many cases of myelodysplastic neoplasms. So genetic abnormalities in MDS obviously go hand in hand, and 90 to 95% of MDS cases have at least one genetic abnormality. As a result of that, most cases also have multiple abnormalities that also tend to cluster together. So in our discussion, I wanted to focus on a couple of things. And so the first thing I want to talk about is TP53. TP53 mutated myelodysplastic neoplasms are what we call a primary progressed disease. It is frequently associated with prior cytotoxic therapy. It is nearly ubiquitous in the fact that there's a complex karyotype and genetic instability. And TP53 is often the sole and also the founding driver mutation. It can present as many different types of MDS, across the morphologic subtypes, as we saw in the previous slide. It can either present with ring sideroblasts, with excess blasts, or within single or multilineage dysplasia. This paper is from Nature Medicine in 2020, and the QR code can take you there. But broadly speaking, when you look at TP53 mutation status, here we're looking at the absolute neutrophil count and also the bone marrow blasts. And if you have wild-type TP53, you can see that the absolute neutrophil count is pretty okay. It's not neutropenia, and the bone marrow blasts are pretty low, around 3%. If there is one TP53 allele mutation that doesn't really significantly change from wild type, where you can see the orange bars, neither does the ANC decrease substantially, nor does the bone marrow blast increase statistically significantly. However, when you have a multi-hit or biallelic mutation of TP53, you can see that there's a statistically significant difference in the ANC, which drops to 1,000, and a statistically significant increase in bone marrow blasts that go from the 4% range to the MDS-EB1 range into 9%. Now, so that really shows that the allelic state influences TP53 mutated MDS. The multi-hit cases have the inactivation of the second TP53 allele due to inactivation or loss. So it could be either the inactivation or loss, which would result ultimately in biallelic inactivation. Now, multi-hit mutations are more frequently therapy-related with higher blast counts and with a more complex karyotype. And if you look here, the probability of overall survival over time in cases with TP53 mutated MDS, the blue line is the multi-hit, and you can see that the survival is significantly steeply shorter compared to the wild type and the one mutation, the gray and the orange lines here, which are pretty similar. And so there's no statistically significant difference between one mutation and wild type TP53. So on the left is again the probability of the overall survival for TP53, which I'm showing you again here, but in contrasting that to the other indicator, which is the cumulative incidence of AML that occurs in these cases. And similarly here, you can see that the multi-hit TP53 mutations in the blue line have a steep, sharp, high inclination for incidence of AML compared to the wild type and the single mutant, which are pretty similar and not statistically different from one another. So it's important to consider the allelic state of TP53. Not only is it important to consider the allelic state, but also to think about the fact that it is uniformly aggressive across all subtypes, meaning that there is no independent influence on the outcome of therapy relatedness, complexity of the karyotype, whether there are less than 20 or less than 10 or more than 20% blasts, the blood or blast counts anywhere, and the TP53 mutated myeloid neoplasms then theoretically should be classified together into a single disease category, irrespective of blast percentage. That is the question. Similar to how we used to classify therapy-related myeloid neoplasms before. So here, if you look at the overall survival, the blue line is AML with TP53 wild type. The green line is MDS excess blasts with TP53 wild type, and doesn't matter whether it's MDS excess blasts or AML, they're doing much better than the AML with TP53 mutation and the MDS with TP53 mutation. So the blast count does not make a huge difference here. So like I said, there's no independent influence on the outcome, either by therapy or by complexity of karyotype or by the blast count. So MDS with mutated TP53 is the diagnosis in the ICC, and MDS with biallelic TP53 inactivation is the terminology used in the WHO. So when you look at it, the differences are highlighted in kind of yellow highlight. The blast percentage in the ICC is 0 to 9% for this diagnosis, and I'll tell you why. In the WHO, again, it takes it from 0 to 19%. So if you have in biallelic TP53 inactivation, up to 19% would be considered MDS in WHO 5, but the ICC would only consider it till 9%. And that is because the TP53 mutated cases that have 10 to 19% blasts in the ICC are considered MDS/AML with mutated TP53. So they have combined the excess blast category with AML, and there are a variety of reasons for this, which includes the patients being able to be put on different clinical trials, being able to be treated with either MDS or AML therapy, and so the ICC has combined this. So ultimately, if the patient has TP53 mutation, you have to look at the blast count. If it's less than 10, then in both cases, it will be MDS with mutated TP53 or biallelic inactivation of TP53. If it is more than 10, then in the ICC, it will be MDS-AML, and in the WHO 5, it will still be MDS. So how do we get multi-hit TP53 mutation? So here also the differences between the ICC and the WHO 5 are highlighted. You get multi-hit TP53 mutation either by one TP53 mutation, which has a variant allele frequency of over 50%. This is the same in both criteria. So if the variant allele frequency is over 50%, then automatically you can assume that there's biallelic inactivation because you have more than 50% of your alleles being mutated, right? So that is one consideration, which is the same. Now, the other considerations are one TP53 mutation with 17p loss, one TP53 mutation with copy neutral loss of heterozygosity of TP53, or two TP53 mutations. Now, the ICC highlights the variant allele frequency in these cases to be above or equal to 10%, but the WHO5 does not care about the variant allele frequency. So even if it's under 10%, they will still allow the categorization of biallelic inactivation, right? So whether, so if the patient has TP53 mutation and 17p loss, and it doesn't matter what the VAF is, by WHO 5 standards, that's already met the criteria for biallelic TP53 inactivation. But for ICC criteria, you need to check the VAF for TP53 mutation. It has to be above 10%, right? And remember, if it's above 50%, then it doesn't matter because in both classifications, it has already met the criteria. So after TP53, the next thing we'll talk about is deletion 5q. Now, MDS with deletion 5q luckily has no changes between the ICC and the WHO 5 criteria. You can see here the characteristic morphologic changes that you see with deletion 5q with the kind of small unilobate megakaryocytes. It's important to remember that this is an interesting and important category to consider because it does have favorable prognosis with good response to lenalidomide. And with diagnosis, deletion 5q alone or with one other cytogenetic abnormality is allowed, except for monosomy 7 or deletion 7q. That does not allow MDS with deletion 5q diagnosis to be made. Importantly, there can be no increase in that. And in these cases, anemia is common and thrombocytosis is common. Megakaryopoiesis is really ubiquitous that all cases have this megakaryopoiesis. And these cases may have a single TP53 mutation, but not biallelic TP53. So the single TP53 mutation obviously will have a low VAF, right? Because then otherwise it would characterize it as biallelic TP53. Because if the biallelic TP53 criteria is met, then you cannot use MDS with deletion 5q. You have to put it in MDS with biallelic TP53 inactivation. Moving on, let's talk about ring sideroblasts. Ring sideroblasts are obviously, we all kind of identify them. Pretty simple and effective iron stain, right? And so you look for the collection of the siderotic granules around the nucleus of the red blood cell. For the trainees, normal siderotic granules are kind of a few, usually less than 6. But if you have clusters of them, and importantly, if they cluster in a way that they become circumferential around the nucleus of the red blood cell precursor, and they are more than a third of that circumference, then you can call that positive. And then again, you count these ring sideroblasts within as a percentage within all of the nucleated red blood cells. So ring sideroblasts and MDS are strongly associated with spliceosome factors, specifically RNA splicing factor SF3B1, but it could also be other spliceosome factors. So SF3B1 is mutated in around 70% of MDS cases that have more than or equal to 15% ring sideroblasts. So we do need to count the ring sideroblasts. SF3B1 mutation is very rare in myelodysplastic neoplasms that lack ring sideroblasts. And it is an early founding mutation in MDS. So even within the spliceosome factors, it is actually kind of different. Both ring sideroblasts and SF3B1 mutation have been associated with longer survival. So overall, it is a better prognosis condition. So then the question is, can we redefine myelodysplastic neoplasms with ring sideroblasts based on SF3B1 mutation? And the reason for this is that MDS ring sideroblast cases that lack SF3B1 have a poorer prognosis. So should they be classified separately? And so here you can see that the blue line are those cases of myelodysplastic neoplasms that have ring sideroblasts, but they do not have SF3B1, and they do worse. And so the question is, SF3B1 by itself actually makes it a better prognosis. And so should those cases be classified separately? So let's look at MDS with mutated SF3B1, which is the name for the disease by the ICC. And the name for the disease with the WHO5 is MDS with low blasts and SF3B1 mutation. So in both cases of the ICC and WHO5, you find that the blast count has to be less than 5% in the bone marrow and less than 2% in the blood, right? Because otherwise you're going to go into the excess blast category. The SF3B1 mutation, again, the ICC likes to see that variant allele frequency of 10%, and the WHO5 does not care about the variant allele frequency, and any variant allele frequency will work. The exclusions to this diagnosis, again, like we discussed, in both cases include monosomy 7, deletion 7q, deletion 5q, or a complex karyotype. Again, a multi-hit TP53, which would either be due to inactivation of multiple alleles, over 50% VAF of TP53, or other criteria that we've discussed, will also exclude MDS with mutated SF3B1. The ICC also adds 2 more exclusions, which are RUNX1 mutation and also abnormalities at the 3q26.2 locus. In the cases with MDS with mutated SF3B1, single versus multilineage dysplasia is not relevant. The ring sideroblast will be present in the vast majority. And in the cases of the WHO5, if you don't have over 15% blasts, 15% ring sideroblasts, it can substitute if SF3B1 mutation status is not known. So if you are using the WHO5, if you have, let's say, 30% ring sideroblasts, you can call it, even if you don't know if SF3B1 is mutated or not. So that's kind of an interesting thing that they have allowed you to give a diagnosis which has SF3B1 mutation inside the name, but even without knowledge that you have SF3B1 mutation. So ultimately, this means that, could we think about a more genetically inspired MDS classification? And if you do extrapolation of the genomic landscape of MDS, the genomic groups through, these Bayesian networks can be applied to the whole MDS cohort. And here on the right, you can see these groupings, and the size of each node accounts for the number of correspondent genomic or cytogenetic alterations. And the color of each link reflects the odds ratio, or the shades of brown represent mutual exclusivity here. So you can see this, that if you have MDS with isolated deletion 5q, and you want to consider a more genetically inspired classification, you can consider going through the questions of deletion 5q, complex karyotype TP53, SF3B1, SRSF2, UTAF1, and AML-like mutations. And then based on that, you can have a completely different grouping of MDSs. And this is published in the Journal of Clinical Oncology in 2021. So, we've talked obviously about morphology, like genetics a lot, but ultimately this conversation was supposed to integrate morphology as well. So let's talk about morphologic parameters that can influence the MDS diagnosis and classification. And the morphologic parameters basically include the blood blast percentage, and its utility still remains that increasing blasts confer a poorer prognosis independent of the bone marrow blast count. So these are the blood blasts. The bone marrow blast percentage also confer a poor prognosis, and these are important because they're also included in several schemes of score status, like the IPSS score. Our rods, like we've always known historically, confer a poorer prognosis, even if the blasts are not increased, and so our rods in general are considered a marker of poorer prognosis. Multilineage dysplasia, by and large, does have a worse prognosis than cases with single lineage dysplasia. Ring sideroblasts are interesting because they are a marker of likely SF3B1 mutation, but they do not appear to be meaningful if the mutation status is not known. So remember, we've talked about if the ring sideroblasts are present and there's no SF3B1 mutation, those cases technically do a little bit worse. But if they're present and the mutation is also present, they actually don't do that worse. Fibrosis, by and large, confers poor prognosis, and hypocellularity may indicate a subset of cases that are likely to respond to immunosuppression, but the prognostic effect of these is uncertain. So it is important, I think, as pathologists and hematologists, for us to consider how blasts have a powerful prognostic impact in myelodysplastic neoplasms. And, this is all data from 2012, but you can see that, the patient marrow blast subgroups and impact on survival is heavily dependent on, whether our MDS survival and the blast percentages are categorized differently, right? And so you can see here that if you have over 10% blast, which is like this kind of lighter gray, the survival is the poorest. 5 to 10 is even better. less between 2 and 5 is even better, and less than 2 is even better, right? So it's not that we count this for no reason. Scientifically, it has been proven that as the blast counts go up, the outcome actually becomes worse. And so the thresholds of 5% blast in the marrow and 2% blasts in the blood still define myelodysplastic syndrome with excess or increased blasts in both the ICC and the WHO. So the blast percentage is still very important from both criteria. And we have found that whether you call it myelodysplastic syndrome with excess blasts or increased blasts, they are genetically heterogeneous. Blasts do behave as a continuous variable, and rigid thresholds are not optimal to define disease entities. And that is why the ICC decided to do MDS/AML after 10% blasts, because it felt that putting it together in one category would be beneficial for our patients. MDS-EB2, which is a category it's just in the WHO because it's not in the ICC. In the ICC, the 10 to 19% category has been renamed MDS/AML, right, together. And this is 10 to 19% blasts. And it reflects the biologic continuum between MDS and AML. And the question arises, could it be that it's because the 20% threshold is arbitrary? Historically, 30, 40 years ago, AML needed 30% blasts. I don't know if people remember that time, but it was before my time, but it was 30%, right? And then they moved it to 20%, and then MDS-EB1. So, the other thing to consider is that sometimes there is imprecision in counting blasts, right? I mean, we can all sit together and maybe somebody thinks it is a blast and somebody thinks it's not a blast, right? And I've always wondered about this. Like sometimes I get cases and I'm counting 19% blasts. This is before this MDS-AML. What does that mean? Is that different from 20%? No, right? And so it's probably better to keep counting. In those cases, I would keep counting to like 1,000 cells, right? Because I want to be able to reflect that, okay, if I can get 20, I can call it AML. Or if I really on multiple counts would get like 18%, I would say MDS with increased blasts, highly worrisome for evolving acute myeloid leukemia, because by definition, I couldn't call it AML. But that doesn't mean that I don't think that biologically it's not AML, because I think it is. Remember that there is across the world, at least in resource-rich settings, an increasing use of intensive AML-type therapies in MDS patients with more than 10% blast. So it's possible that based on the cytogenetic data, they can do intensive chemo induction, right? And so that's why I believe the MDS-AML category was created by the ICC. And in general, I don't care about either one of the classification. I don't believe in one versus the other. I actually just wanted one classification. So to me, it doesn't matter which side you're on, because if people are taking sides, I just want what's best for the patient and what's best for the hematologists who are treating the patients. In any case, the good news is that the MDS/AML patient is eligible for both types of trials, especially since the optimal treatment approach is uncertain. So there are two morphologically redefined or defined subtypes in the WHO-5, and that has to do with MDS, which is hypoplastic. This is defined with low blasts and a bone marrow cellularity of less than 20%, and no isolated deletion 5q, SF3B1, or biallelic TP53. There is a morphologic and genetic continuum between paroxysmal nocturnal hemoglobinuria, aplastic anemia, and MDS, which is hypoplastic. And so you need to kind of consider that. The other one is MDS with fibrosis. Here you do have increased blasts, which is 5 to 19%. Typically, it's grade 2 to 3 fibrosis, and you cannot have biallelic TP53 mutation, because obviously that would make it MDS with biallelic TP53 inactivation. Fibrosis does confer adverse risk in MDS, and here you can see two overall survival curves. On the left are bone marrow blasts less than 5%, and on the right is bone marrow blasts more than 5%. In both cases, the MF fibrosis score of 1 does much better than the fibrosis score of 2 and 3. Again, with increasing blasts, these two lines come closer together, but even then, the overall survival is much better in those cases that do not have an increase in fibrosis. The other thing that we talked about in our morphologically based things, we talked about fibrosis. We also talked about multilineage dysplasia. So multilineage dysplasia, here I'm just showing you, obviously, this very nice megakaryocyte with widely separated nuclear lobes. You can see almost like a kind of a micro-mega karyocyte. You can see all sorts of kind of morphologic dysplasia here. You can see granulocytes that have hypolobation and also hypogranulation. They look really washed out, and you can see erythroid cells with budding, etc. So like trilineage hematopoiesis. So when you think about the MDS classification in 2024, again in adults, right, and you put together the ICC versus the WHO versus 2017, the ICC will have MDS with mutated SF3B1. The WHO5 will be MDS with low blasts and SF3B1, and 2017 was MDS with ring sideroblasts, right? And so these are all the lower risk MDSs. Deletion 5q, lower risk. MDS not otherwise specified is kind of still low risk because there's no increase in blasts. And in 2017, you also had MDS unclassifiable, which you do not have anymore in the ICC and the WHO5. Higher risk MDS is MDS with excess blasts per ICC, MDS with increased blasts by WHO5, and it was EB1 in 2017. The EB2 or the IB2 category becomes MDS/AML in the ICC. MDS with fibrosis is a WHO5 morphology-based diagnosis. And MDS and MDS-AML with mutated TP53 or MDS with biallelic TP53 inactivation also become a higher risk myelodysplastic syndrome. So what is the classification process then? When you see a patient, what do you think? So the first question is biallelic TP53 mutation present, right? So you are now thinking that there's myelodysplastic syndrome and you're thinking, is it excess blast? Is it this? Is it that? The important thing now is if you have access to TP53, figure out whether there is inactivation, a biallelic inactivation of TP53. Obviously, it's important to consider if the blasts are more than 5% in the bone marrow or more than 2% in the blood because you're thinking about excess blasts or increased blasts. Is there isolated deletion 5q? Is there an SF3B1 mutation? Or is there single versus multilineage dysplasia? And what is the marrow cellularity of fibrosis? Because in the WHO5, those things are important. Remember that the blast increases would be considered MDS-AML if more than 10% per the ICC. Just some pictures for you for the trainees. Megakaryocyte morphology, obviously by nature, they're polyploid cells normally, and so they look a little bit strange. Really, you have to have strict diagnostic criteria to call something morphologically aberrant. And so widely separated nuclear lobes, micromegas, pawn wall megas, etc. are important. Again, erythroid dysplasia, you consider megaloblastoid changes, nuclear budding, nuclear irregularity, dysynchrony between the nucleus maturation and cytoplasmic maturation, and also ring sideroblasts. It's important in any case with cytopenias. Doing an iron stain can be very helpful because you can maybe uncover ring sideroblasts. In granulocytic dysplasia, you are thinking of hyposegmented nuclei and hypersegmented nuclei. Both of them can show dysplastic. It can be nuclear twinning, it can be ring nucleus, it can be nuclear excrescences, and importantly, hypogranularity of the cytoplasm, and often that really shows up. It's actually kind of nicest sometimes for me to see it in the blood, but even in the marrow, you can sometimes see it when you can contrast it to the background. We published a paper that we recently published in Cytopathology Journal about the phenotypic clues that predict underlying cytogenetic or genetic abnormalities in myeloid malignancies. This paper talks about what features in all myeloid neoplasms, right? A lot of AMLs and MDSs, kind of what features can be helpful. So I think for the trainees, when you think of cup-shaped indentations in the nucleus, you think of NPM1-FLT3. When you think of these types of small megakaryocytes with non-lobated or hypolobated nuclei, you can think of MDS with deletion 5q. This also kind of highlights for the trainees what it looks like to have dysplasia in the erythroid series, the granulocytic series, and the megakaryocytic series with some illustrations, which I think can be helpful if you are a trainee. So ultimately, I think that, I love to always show this. It's inspired by Dr. Rob Hasurgian from Massachusetts General Hospital, who one time I attended one of his talks, and I really liked how he presented this, so I kind of copied it in a way. But basically, these are the blast cutoff lines, right? If you start from the circle, this is the 5% blast cutoff, this is the 20% blast cutoff. And in the middle, you have clonal cytopenia of undetermined significance. And then if it's under 5%, you can have MDS deletion 5q, MDS TP53, MDS low blast, or MDS SF3B1. Now, once you go above the 5% cutoff, you're now in the MDS excess blast category. And remember that ICC will have an MDS/AML category in between. And then when you hit the 20% cutoff, you are now in AML. And so remember to think of all of those things. In my last slide, I will share with you this idea that there are still cases where you can consider classifying MDS on genetic parameters. And the way that happens is that, in this paper, which was published, and you can take the QR code, go directly to it, they took the diagnoses that were done in 2017 and in 2022, and this was obviously by counting blasts, and then they redefined it into 9 genetic subgroups. SF3B1 mutated, 5q deleted, biallelic TP53, spliceosome factors, which are different from SF3B1 because SF3B1 has its own characteristics, ASXL1 mutation, RUNX1 mutation, and complex karyotype, right, and AML. And so based on these categories, it's very interesting because the survival probability broke down beautifully separately. And so the question then became, is it time that we stop classifying based on blast count? And we've obviously understood that the blast count is important, and I don't think it's going away, but it is important to think about genetic patterns and the classification of myelodysplastic neoplasms. And so with that, I will end, and I thank you very much for your attention. And please, if you feel free to reach out to me on social media, to connect with me on any one of the social media platforms, I'm happy to discuss any hematopathology case. Thank you.
Thank you, Dr. Kamran, for such a lucid talk. And now we'll have some question and answers. Okay. So, sir, let me start with this simple question that blast counting is not going anywhere. Agreed. So if a bone marrow, this is a real case scenario where there is a 70-year male with pancytopenia of 1 year, and the marrow aspirate is cellular with 5% blast, no or rods. And on bone marrow biopsy, there is on CD34, 7% CD34 positive cells, and CD117 showing 17% cells positivity, and no other marker being done on IHC. So this is a question where we like to ask, is there any basic IHC panel to be put on bone marrow biopsy where we can, identify at least the MDS with increased blast more objectively?
It's a good question. So the short answer is no. I think that, that is your practice is excellent, because here also we would do 34 and 117. I think that, one of the part of what I did not discuss in the talk was flow cytometry. Now, there are some elements in flow cytometric analysis that can be very helpful in identifying abnormal blast populations. And those can be, myeloid blasts with aberrant CD7, aberrant expression of other different markers. And, so here at Michigan Medicine, we do have some tubes in our flow panel that look at blast categorizations with different types of aberrancies. However, in the case that you're describing, Dr. Asta, 17% blast on CD117 is already pretty high. So you're not really worried about them being, unless the patient got chemotherapy and it has a regenerative marrow, it's such a high number that it automatically falls into the categorization of MDS IV2 or MDS/AML, depending on which categorization you use. And so I think that the flow phenotypic or the flow phenotypic or kind of immunohistochemical analysis plays less of a role. Now, it's true that if your blast count was very low, let's say it was 3 or 4%, and you were seeing some abnormalities and there were cytopenias, then that would be very helpful. But it would probably be helpful in things like at a very low grade MDS where they may not even treat someone. So I think that from the perspective of practicality, I think we also do 34 and 117 by IHC. And then if your flow markers, because in the introduction I at least reported you guys have really good flow. So I mean, you can consider thinking about aberrant markers and myeloid blast to kind of help confirm the diagnosis. But ultimately, I think if the blast count is increased, oftentimes, Dr. Asta, we get cases where the blast count is increased, but there are no phenotypic abnormalities. And we report that as saying without phenotypic abnormality. And so really it ultimately comes down to the number.
So then what is the importance of early erythroid markers like E-cadherin or CD71, where we want to discriminate between early erythroid precursors from the blast in the bone marrow biopsy? So this third marker will it help us to differentiate whether those 117 positive cells are truly myeloblasts or early erythroid precursors? So what's
Yeah,
your practical take on it?
That's a great question. So for me, it depends on how good your fixation is. Based on morphology, I think that you can tell the earliest erythroid markers, typically the erythroid cells. Typically, they have this very characteristic three nucleoli with one with a comma and comma shape touching the nuclear envelope. And so, but you're right, if there's lots of them and you want to really rule them out, then you're doing E-cadherin and CD71 can be very helpful. Ultimately, though, that I think that in this case that you described, even the CD34 positive blasts were a little bit increased. So ultimately, it's a subclassification issue, right? Because I think that in your case, you have a myeloid neoplasia. The question is, are you going to call it MDS-IB1 or MDS-IB2, right? And then I think that if you do rule out that there isn't as many erythroid precursors as the CD117 is showing, then you can suggest that, we favor MDS-IB2. So I agree with you that looking at erythroids, if the morphology is not clear, or maybe it's not from your institution and it's difficult to evaluate, then yes, I agree that looking at the IHC for erythroids can be very helpful.
Okay. Sir, there is another case scenario where there is a 65-year-old male with a peripheral blast count of 35% done elsewhere. Flow cytometry showed 14 to 15% blast and 14 to 15% blast, and NGA showed U2AF1, WT1, SXL1, TET2. So where we will classify this as MDS or AML?
35% blast with AML, right? I think it's clear cut. And, with those, it's possible that it might have been a CMML that became an AML, but either way, at this point, 35%, it's AML.
Yes, sir. So what is the status of ALIP now?
Abnormal localization of immature precursors.
Yes. So,
I think that, I was trained by someone who was very classically morphologically trained, and he's retired now. And so I do look at those. Ultimately, I think obviously the value of that is much greater if you do not have access to phenotyping, right? But if you have access to phenotyping and flow, that's such a great question by Dr. Halder. I have to say that, I haven't thought about ALIP for a while, but, when I was trained, I did think about it. And I do agree that I think if you are in a setting where you may not have access to a tremendous number of phenotypic markers, I think that ALIP can be helpful. But ultimately, you can't use it in it because it isn't part of the classification schemes, but I think you can use it to think about what's happening to your patient.
So there is another question by Dr. Srinidhi. 66-year-old with high hemoglobin and marrow flow is not ordered and NGA shows TP53 as 56%. So what is the diagnosis?
56% VAF. So with 56% VAF, that already qualifies this person as having biallelic inactivation because it's more than 50%. So high hemoglobin is kind of unusual. I don't know if the person is a smoker or not, but I think ultimately what you need though, Dr. Nathani, is you need to look at so I think when she says marrow is silent, it means that it's probably no blast increase, I assume.
So, can I come in? So, there are no blasts, no dyspoisis, nothing. So this patient was just evaluated as a referral patient from another department by the hematology department, and because he had an incidentally detected high hemoglobin, never smoker, so they did a marrow and they sent an NGS for myeloproliferative to rule out a myeloproliferative, but we found a TP53 which is pathogenic and at 56%. So now high hemoglobin with TP53, we just don't know what to do with it.
Yeah, that is a very interesting case, Dr. Srinidhi. I think that, I would love to know what ends up happening with this patient. Apart from the high hemoglobin, is there anything else? Like, is there any cytopenia, like leukopenia and neutropenia?
No. That's why we're just very, very confused because, so we didn't order a cytogenetics also on it, just, so because we thought high hemoglobin, so probably we were looking at JAK2 or something like that. And
Are you sure he doesn't have like a lymphoma circulating in the blood or bone marrow that could have TP53 mutation?
so that I guess has not been evaluated. But then I think if there was a lymphoma, it would at least light up on a PET, I think.
Right. So like, is the PET normal?
Yes. So nothing lit up on the PET. So
Wow.
it's very,
I mean,
very.
I would, and has the blood been flowed?
No, there has no float been done.
No flow, sorry. So I think that, and does the patient have access to flow?
Yes, it's our institute, so
Oh,
Dr.
perfect. So I
Astha is
think that,
there.
maybe one thing to consider is to look at the non-myeloid populations, look at lymphoid populations, make sure that there's no B-cell lymphoma that could also have the TP53. It could be that it's just like floating around in the blood and you just haven't got it. I understand that the PET is negative, but sometimes you can have like circulating lymphomas that may not be lighting up, especially since that it's just an interesting scenario. And so I would rule out the non-myeloid, like maybe some lymphoid reasons for it, like you can have mantle with TP53. Is the patient sick?
He was. So he basically came with neurological complaints, and he seized once or twice. And
Wow. That's the other thing the presentation looks like kind of just difficult. And so the other thing I was thinking, I don't know about TP53 in intravascular large B-cell lymphoma, but like, I think that this might, TP53 of over 50% is definite and pathogenic is a problem. So there's something happening. It's just that we have to figure out what it is. So I think perhaps looking at the lymphoid populations in the blood may be the next good step.
Okay. Thank you so much. Thank you.
So the next question is peripheral blood NGS and MDS, again by Dr. Nathani. Is it recommended or should we do it for marrow only?
I think that it depends really on, I think it depends on the blast count. I think that if you can, if the blast count is very high or high enough, right? I mean, because what you need is nuclear material to study, right? So the red cells obviously won't have the nuclear material, the platelets won't have it either. Ultimately, if most of it's just normal neutrophils, then I think that, it may be not as valuable. So if you can get into the bone marrow, I think that that's probably most helpful.
So there is another question by Dr. Jitendra. So MDS with IB2 with 12% blast should be treated as AML. So that depends. I mean, which classification do you practically follow, ICC or WHO? I don't know.
Yeah, I think it's a great question, Dr. Jitendra. First of all, I have to admit, I'm not here as a pathologist. I'm not involved with those decisions. I help consult with them, and I think ultimately that would make it MDS/AML per the ICC based on that blast count. So you do have the option using the ICC to treat it as AML. But I think ultimately beyond the 12% blast, I think the patient's cytogenetics will be very important. Kind of, is this a very high risk one? Do you want to, is the patient's clinical status kind of healthy? If they have a good performance status, maybe, so I think that there's so many factors that would go into it. So, I apologize. I'm not an expert in the treatment, but certainly with the ICC, you are allowed to consider it as an MDS/AML for the specific reason that if you wanted to treat the patient with AML therapy, that would be possible.
Okay, so how often do you do flow cytometry in your suspected MDS cases? Is it only in the cases with increased blast, or even with less than 5% blast, you attempt the flow cytometry? How it is the practice there?
So that's a good question. So we actually do flow cytometry quite often, even when the blasts are not significantly increased. So I think that even if they're under 5, like even with 3 or 4% blasts, if there's clinical suspicion, so we always run a triage kind of tube first to kind of enumerate how many blasts we're getting. And then beyond that, we have 2 tubes, one which has myeloid with T aberrant markers and myeloid with B aberrant markers to kind of look at. And there are times when we can pick up aberrancies, and I think that can facilitate or help the morphologic diagnosis, but I think it would be very difficult to make an outright diagnosis just based on flow. So in flow, we'd say something like a small population of blasts with the following aberrancies is noticed, and then you need to correlate with the bone core biopsy.
Okay. So on that note, if there are bone marrow aspirate and biopsy morphology and the rest of the studies like molecular, the NGS, the cytogenetic studies are awaited, and you're finding dysplasia, not increase in blast, but morphological dysplasia in your morphology. So how do you formulate the report, or do you hold it till all the studies results come in and give an integrated report sort of thing, or you suggest that?
Yeah, so that's a great question. And I think it's a problem that most of us have to kind of address. So I think that, so it really depends. So as a pathologist here, and, hematopathology is separate here from hematology, so they really do we are the ones who write the reports. And so ultimately, I think it depends on your relationship with the hematologist and also how sick the patient is. I often do not wait for all of those things to come back but I definitely, so I won't be as definitive perhaps if it's on the cusp. So for example, if you have 12% dysplasia, I might just say hypercellular bone marrow with 12% dysmegakaryopoiesis in the setting of cytopenias, worrisome for myelodysplastic neoplasm if all reactive causes of dysplasia are ruled out, see comment. And then I'll say, we're pending cytogenetics, pending NGS. And if a clonal marker is found in those, then this is definitively MDS. However, reactive causes need to be considered, right? Because we're not talking about AML. We're talking about MDS. We're likely talking about either a low grade or like an intermediate grade MDS. And so I think ultimately I think we will do harm to the patient if we give them a myeloid malignancy when they don't have one. And I don't think we're doing any harm by stating that there's an abnormality and we're worried about it, but let's wait for the clone. So otherwise, if the patient is totally stable and they don't mind waiting for like 2 weeks, I don't wait though. I typically just put it and then I addend it. When the thing comes back, then I make it more formal and then I'll say myelodysplastic neoplasm, see comment, and then I'll give all of this. So, as long as you have a good relationship with your hematologist, you should be okay.
So, sir, this is another case scenario where there is a 35-year-old female with new onset leukocytosis and thrombocytopenia. The peripheral blood shows 14% blast and marrow shows 16% blast with this granulopoiesis and around 20% of myeloid cells. Bone marrow biopsy showing 3x3 reticulin fibrosis and NGS showing DNMT3, NPM1, PTPN11, and ATM mutations. So should it be treated as AML? First of all, should we classify it as AML and should be treated as AML? That's the question. And what is the relevance of fibrosis? That you have already told that yes, fibrosis will lead to a worse prognosis. But here the question is whether to consider this as AML or not.
So it seems to me that the patient is young, right? She's 35 years old. And it's interesting that there's new onset leukocytosis because what it seems to me that the bone marrow fibrosis really and the leukocytosis really aligns with this being myeloproliferative and also myelodysplastic. So to me, this looks like this was an overlap myeloproliferative/myelodysplastic neoplasm that is increasing in the blast count and going towards AML. So that's kind of what I'm thinking based on the fibrosis, right? And so it doesn't seem, if there was no increase in blast and if you didn't have all those important findings on NGS, then I would have thought about other causes for fibrosis. You can have autoimmune causes. She's a young woman, maybe she has autoimmune disease. But here you're obviously in the malignant myeloid world. And so with the 16% blasts, I would say that again, with the ICC, you are allowed the MDS/AML. I think she's young and depending on her performance status, again, I'm not the expert in treatment, but I think that you could treat as AML if you felt that, it needed to be addressed pretty quickly so that you can get the patient into remission. And then, I don't know, maybe even consider transplantation given that she's young. If that's available to you. So I would say that, again, the fibrosis means that things are worse than if there was no fibrosis. And overall, the fact that they are both myelodysplastic and myeloproliferative features here, she's too young to have CMML, and those mutations don't sound like CMML, but I wouldn't be surprised if there was probably even an underlying MDS/MPN type of picture.
Sir, one last question that in how many cases of yours with single TP53 mutation, the morphology is normal or is it always abnormal?
It's a good question. I don't know if I know that data, but I think that if it's single, most likely, you have cases with morphology with TP53 can start looking really ugly. I don't want to guess because I actually don't know that data. I think that I don't know if I would know the number, so I don't want to say something wrong.
Sure, sir, sure. So I think.
Can I
we are-
ask Dr. Asta?
Yes, sir. Yes, sir, Tathagat, sir, please.
Good evening to you and good morning, actually. I'm Brigadier Tathagat here, and this is the first case which Dr. Asta and I actually worked up yesterday, and she put it up very well. Just to update, this patient is 73-year-old, persistent pancytopenia for 1 year, asymptomatic except for a frequent infections of the upper respiratory tract, otherwise nothing much. And now with this discrepancy of 5% blast in a cellular bone marrow aspirate and 17% IHC CD117 positive blast in the bone marrow biopsy and 7% CD34 positive blast. That's the case scenario. So the question is, how sensitive is CD117 standalone to pick up those myeloblasts, or should it be combined, as Dr. Asta said, with E-cadherin, which are actually positive in the early pro-erythroblast? Your comment on a MDS IHC panel vis-a-vis just 2 antibodies.
Yeah, so, this is an incredible question. Just like Dr. Asta said, I fully agree that if on morphology, you cannot distinguish the early immature erythroblasts from myeloblasts, then I agree that doing a panel with CD71, perhaps, E-cadherin, and CD117 is certainly helpful. Especially to rule that out. However, I think that in your case, given the clinical history and the fact that you have bona fide 7% blasts at least, right? You at least have 7. So you're already in a myelodysplastic neoplasm, right? So we're not worried that this is CHIP or CCUS or anything like that. He has these obviously symptomatologies of being immune compromised because likely of the MDS. So I would say that the question that you're trying to answer basically is whether it's MDS IB1 or if it's MDS AML, right, depending on ICC. And I think that one thing could be that, depending on how would you treat the patient, I guess that is another question. If you felt that the treatment if you, let's say, had 70, if ultimately all those 117 positive cells were blasts, would it be treated as AML? If it would be treated as AML, then I would say that differentiation is crucial, right? But if it would still be treated as MDS, given his performance status or what is available, then it doesn't matter as much. However, I fully agree, by definition, ruling out the erythroid precursors in that CD117 positive population is very important.
Just to just highlight this further, I'm just taking a minute extra, is that the moment they got 17% CD117 blast, the clinicians immediately send it for FISH for MDS cytogenetics as well as NGS for mutation, and both are negative. So they have decided to put this patient on azacitidine as of now.
Yes, I think that it basically. And how old was the patient? 70 something, I believe, right? 73?
Yeah, 73, 70.
Yeah, so and it depends on their performance status, but I think that seems like a reasonable next step. But
Thank you.
The truth is that this patient will eventually, like, if without treatment, will eventually transform into AML. Like that's what's next for the patient.
Very true. Very true.
Right.
Thank you so much.
My pleasure.
Thank you, Dr. Kamran, for such a nice interactive session. And on popular demand, I think we'd like to have a flow session also from you, especially in MDS, that I'll coordinate with you. And yeah, at the outset, I'd like to thank MKO team also for supporting us, giving us support for this Zoom channel and very smoothly run. I'll thank Dr. Rahul Bhargav for initiating this innovative in hematology. He has been a continuous motivation and support for this series. And thank you, everyone. Good night, everyone. Thank you, Dr. Kamran, once again. Thank you all for joining.